Okay, good morning, everyone, and welcome to April 2022 Journal Club. We would like to begin with an acknowledgement on the land on which we work, study, and live. We recognize that many Indigenous nations have long-standing relationships with the land upon which the work of the University of Toronto's Department of Medicine is conducted. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. Land acknowledgements are only a starting point for larger conversations. More concrete acts of restitution and transformation are needed to address underlying inequities and blatant discrimination in the distribution of resources between Canada's First Peoples and settlers. We have two very exciting acronym presentations from PGY4 residents this morning. Please all remember to keep microphones on mute. Feel free to comment in the chat box, and there will be time allotted for questions after each presentation. To start, a warm welcome to Dr. Rachel Johnston, PGY4, to review a trial of geriatric medicine oncology, the GAP70 study. Rachel, please go ahead.
Thank you for the introduction and good morning from Baycrest. Today I'm going to be presenting the GAP70 study. This is an evaluation of geriatric assessment and management on the toxic effects of cancer treatment. The GAP70 cluster-randomized study that was published in the Lancet in 2021. I have no disclosures or conflicts of interest. And the objectives for today are to review the GAP70 study, its rationale, critically appraise it, and discuss implications for practice. And to start out with some context, adults over the age of 70 are underrepresented in clinical trials that establish the standard of care for treatment of advanced cancer. Older patients are also more likely to express that the goal of cancer treatment is to minimize toxic effects and maximize function and quality of life versus prolonging life. So having a measure for chemotoxicity is therefore very important for patients and oncologists as well. In 1999, the National Cancer Institute published this grading system for chemotoxicity that runs on a scale from 0 to 5. We generally consider a serious or severe reaction to be grade 3, requiring hospitalization, grade 4, requiring ICU stay, or grade 5 as a reaction resulting in death. Oncologists often use the ECOG tool or the Karnofsky performance tool as sort of crude functional assessments to predict chemotoxicity. But we know from the literature that the ECOG and Karnofsky tools do not accurately identify older adults that are at highest risk of adverse outcomes from chemotherapy. So in 2011, the late Dr. Corita and her team developed the CARG chemotherapy predictor tool for older adults, and it was later validated in 2016. So you can see the tool here is in the left table, and it includes more detailed assessments with some demographic information, cancer type, the planned chemotherapy, some lab values, and a bit more detailed functional assessment. And the tool stratifies patients into low, intermediate, or high risk of serious chemotoxicity. And you can see in the high risk group on the right that the incidence of chemotherapy toxicity is to 70%. So based on this literature, ASCO published a guideline in 2018, and they said that patients over the age of 65 receiving chemotherapy should undergo geriatric assessment across 8 geriatric domains of function, comorbidity, falls, depression, cognition, nutrition, chemotherapy toxicity risk, and prognosis. This assessment should be integrated into their cancer management in collaboration with caregivers and primary care. Unfortunately, though, we know that few oncologists actually incorporate geriatric assessment into their treatment decisions for older adults. So that brings us into 2021 with the GAP70 study. This study was funded by the National Cancer Institute. That's a public agency. They looked at a population of older adults that were over the age of 70 with incurable solid tumors or lymphoma with one or more geriatric syndromes across community oncology practices in the US. So they were really trying to drill down on that high risk group that the HURIA tool identifies. And the intervention was a geriatric assessment summary and management recommendations given to the oncologist. The comparator was completion of a geriatric assessment, but no summary or recommendations given to the oncologists. And the outcome was the proportion of patients in each arm developing grade 3 to 5 toxicity over 3 months. So looking at the protocol in a bit more detail, patients were enrolled by their oncologist, and there were 156 oncologists across the country enrolling patients. And the patients had to have a geriatric syndrome or geriatric domain impairment that was determined by their community oncologist. They had to have advanced solid tumor lymphoma at stage 3 or 4 with a plan to start new palliative intent chemotherapy within 4 weeks of study enrollment, i.e. the goal here was not curative intent, but rather palliative intent. And at least one of their chemotherapy agents had to have a 50% or higher prevalence of serious chemotoxicity, also determined by the community oncologist. And they recruited patients across this research network that they've used for previous studies. There are 500 sites affiliated with this research network across the US, all community sites. So they reached out to those sites between 2014 and 2019. And then they organized the sites into practice clusters. So if there was a staff member like an oncologist or an oncology nurse that worked at multiple different community sites, then those sites were grouped into a practice cluster for consistency of care. And they randomized the size stratified practice clusters by a computer with an intervention to usual care 1-to-1. Looking in more detail at the intervention, they based their geriatric assessment on the 8 domains identified in the ASCO guideline. And we won't go through all of the tools that they used in their entire assessment for the sake of time. But if we first just look at the top physical domain, someone in the practice staff would have performed a timed up and go and a short physical performance battery, but then they relied a lot on patient reported outcomes like a falls history and physical health screen to get the full picture. And they did this geriatric assessment at 4 to 6 weeks. So that would have been just at the time that there was a plan to start chemotherapy. So I'm imagining this is just before the oncologist is writing out the dose for chemotherapy. And then they also repeated the geriatric assessment at 3 months when they were looking for toxicity, and then again at 6 months. And some of the most common management recommendations that were implemented, or I should say first that this geriatric assessment was put into a web-based platform on the computer, and then a printout was provided with the summary of the assessment as well as generic recommendations for management, and that printout was given to the oncologist. And then the most common management recommendations that the oncologist implemented were frequent chemotherapy toxicity checks in 85 to 90% of patients, and patient education handouts. Also about 80 to 90% of patients received handouts, and mostly they were in regards to falls and energy conservation. But oncologists more frequently referred to allied health, coordinated with primary care, completed medication reviews, counseled, and also assessed patients' decision-making capacity. And again, the primary outcome they were looking at was this grade 3 to 5 chemotoxicity, and they used the NCI grading scale. And for this, they had non-blinded study coordinators who reviewed the oncologist and patient's medical records prospectively, and then those coordinators discussed the data with the patient and oncologist to confirm that any chemotoxicity that was picked up was truly chemotherapy related. and they had central masked researchers review the anonymized data to confirm those results. Secondary outcomes were the effect of geriatric assessment on treatment intensity, so i.e. the proportion of patients that received reduced dose intensity of chemotherapy upfront, patient survival at 1 year, and as an exploratory outcome, they looked at the effect of geriatric assessment on all of the geriatric domains at 3 months. For their statistical analysis, they set 80% power to detect a 13% reduction in the primary outcome, and they used a generalized linear mixed model where the result was the proportion of grade 3 to 5 chemotoxicity, and that's considered a linear sum of fixed effect and random effect. And here the fixed effect was a binary intervention versus usual care, and the random effect was the practice cluster. Looking at their consort diagram, they started out with 107 practice clusters, but 67 of those, which is 70% of the clusters, were excluded. And the main reason for excluding the cluster was because the oncologist never enrolled patients. They ended up with 40 practice clusters, and of those they randomized 16 clusters to intervention and 24 to usual care. It was a pretty similar number of patients in each group. There were more protocol violations in the intervention arm, which I don't think is that surprising given that there was a bit more complexity of the care with the geriatric assessment. They ultimately ended up with 273 active patients at 3 months in the intervention arm and 297 in the usual care arm. There's a lot of information on this table 1 slide, but I just want to summarize on the top left by describing a typical patient of the GAP70 study as a 77-year-old Caucasian, high school or college educated married man with 3 comorbidities and polypharmacy with some degree of functional physical impairment, waiting for their first ever chemotherapy for metastatic cancer. When we look at the 2 different groups, we see that the intervention arm included more Black patients, more GI cancer, less lung cancer, more prior chemotherapy, more cognitive impairment, and so about 40% in the intervention arm had cognitive impairment and 33% in the usual care arm. Less social support, but a similar degree of functional physical impairment across both groups. Overall, I take this to signify that the intervention arm may have been more vulnerable. For their outcome, the researchers found that 51% of patients in the intervention arm developed grade 3 to 5 chemotoxicity, and 71% of patients in the usual care arm had severe chemotoxicity. And they calculated an adjusted risk ratio of 0.74. And analyzing a little bit further, they arrived at a number needed to treat of 5 with geriatric assessment and recommendations to prevent severe chemotoxicity. And this is driven by a reduction in non-hematological toxicity, and the most frequent presenting complaints there were fatigue, generalized weakness, GI upset, and hypovolemia. There was no statistical difference in the rate of hematologic toxicity. So to put this primary outcome into context, I think what we saw is the authors did identify patients that fit into that high risk box on the Huria tool, and they were able to move them from a risk of 71% down to low to intermediate risk. And to me, that looks quite impressive. For their secondary outcomes, they found that the intervention was associated with less intense chemotherapy. So they saw more single agent regimens and reduced dose intensity in the intervention arm, fewer falls, and more medications discontinued. There wasn't a significant difference in the other geriatric domains. And they also saw no statistical difference in survival at 1 year. So the authors conclude, based on their primary outcome, that geriatric assessment guided management reduces serious chemotoxicity in older adults with advanced cancer And importantly, reducing treatment intensity based on geriatric assessment does not adversely impact survival, and they therefore conclude that this should be our new standard of care. So we'll move on to the critical appraisal. Was the assignment of patients to treatment randomized? Yes, it was randomized by practice cluster. Was the randomization list concealed? The list was concealed to the oncologists enrolling patients. Were the groups similar at the start of the trial apart from the intervention? Well, if anything, I think the intervention arm looked more vulnerable, so that would have favored usual care. And was the follow-up of patients sufficiently long and complete? Yes, they completed a geriatric assessment at 3 months, which was appropriate. Were all patients analyzed in the group to which they were randomized? Yes. Who was kept blind to the treatment? Patients and oncologists were not kept blind due to the nature of the study, but the researchers reviewing the geriatric assessment data and chemotoxicity centrally did remain masked. And aside from allocation to treatment, were the groups treated equally? Well, I have to say no. The oncologists in the intervention arm did receive some basic training at the start of the study in the geriatric domains to put their assessment they received into context. And are the study conditions found in the real world? Yes, they looked at community oncology practices. And are the results generalizable? I think so. But to go through some of the strengths and limitations in a bit more detail, I think that one of the strengths of the study is that the researchers chose the right patient population to answer the question they were after, and they did reach their target recruitment. This is a group of patients that is notoriously underreported, so I think it was really nice to see an effort to explore them further. One of the limitations, though, I'm not sure that the oncologists that enrolled patients are representative of most community oncologists in Canada. And I say that because 70% of the practice clusters were excluded because they didn't enroll patients. And I find it hard to believe, just based on my own clinical experience, that those oncologists were not seeing older adults at high risk. The outcome of chemotoxicity that they chose, I think, is both patient-centered and oncologist-centered. Arguably, there are other outcomes that the study didn't look at that would also be even more patient-centered, but I think this is a fantastic starting point. The intervention addressed all relevant geriatric domains as identified in the ASCO study. But I guess one limitation is how onerous this intervention with all of its patient-reported outcomes might be for older adults with advanced cancer. However, I would argue that going through systemic chemotherapy is also probably more onerous than this assessment. Another strength is that I hope this study might increase geriatric capacity by resourcing oncologists with a bit of primary geriatric training and skills to implement geriatric management interventions in their practice. A small part of me is worried, though, that this intervention might reduce our concept of geriatric assessment to this tick box exercise. I'm mainly thinking of maybe clinic administrators who are just looking at the bottom line of the study. Overall, though, I think we can say that providing oncologists with geriatric assessment and recommendations does reduce serious chemotoxicity among older adults with advanced cancer. And on the whole, I take the study to represent a big win for the geriatric medicine community.
Thank you. Thank you very much, Rachel. Excellent presentations, the slide articulation. Despite this being your first Journal Club presentation, seems like you were a veteran and had done it many times. And so we have many people involved in geriatric oncology. Shabir is on camera with a hand up. Go ahead.
Thanks, Dov. So I echo Dov's comments, Rachel. This was beautifully presented. And although I've seen this paper and discussed it many times and reviewed it, there are a few nice tidbits that you highlighted that I had not noticed before. And so I appreciate that. I want to just go to your strengths and limitations slide because I think you've covered a lot of ground. And I just want to make a couple of quick comments on some of the things you said. So I agree with everything you've said on here. The outcome you mentioned that other outcomes were not included. So in fact, there's already at least 2 other secondary papers that the authors have published reporting some of their other outcomes. And so there's more, and I'm sure there's more to come, but definitely as a package, they've covered a lot of ground. And the other thing you asked about is how onerous is the intervention. So in their group population, as well as our population from Princess Margaret, I would argue that it's not onerous at all. From the vast majority of patients, we do satisfaction data. We ask patients, we do these interventions slightly differently than the GAP70 group, but definitely very few patients consider this particularly onerous, especially if you negotiate with them what they want to do. They're not going to follow everything we do, just like in general geriatric clinic, they're not going to follow everything we do. And that last point is a very interesting one. And I think it's a nice commentary about what is CGA and what is our role, because on the one hand, we will never have enough geriatricians to see every older adult. And yet we know every older adult deserves more geriatric assessment than is currently provided. So we have to figure out how to get to some compromise. And this is one way, but as I'm sure you know, and some of the audience knows, there are multiple other randomized trials now in geriatric oncology that have used slightly different models of care. And several of them have been positive in showing reductions in toxicity with more conventional geriatric models and some that are more checklist models. And so I think a lot of the experts are saying it's really where you are and what is feasible for you. At the end of the day, I think feasibility and rolling this out and typical oncology, I think that's going to be a big challenge because it hasn't happened yet, but this is a huge impetus. Let me stop there, but great presentation.
Thank you.
Rachel, any comment or we'll go ahead.
I so appreciate Dr. Alibai's perspective, especially someone that's so involved in geriatric oncology, and I completely echo everything that you said. I think, as you mentioned, there's the group did look at communication that has improved with geriatric assessment in previous studies. And Dr. Gandel, you had presented at the CGS on the GAIN study that showed a multidisciplinary implementation was also effective at improving chemotoxicity outcomes. So we do have a few different ways depending on feasibility.
Thank you. And just be mindful of time. Perhaps we'll take one more question if there is any other questions among the group. If not, Shabir notes to my comment, GAIN had a 10% reduction in toxicity, statistically significant. So less. Gary, go ahead.
Thanks very much. I mirror the comments, Rachel. Great presentation. I don't know the study in the detail you do, so I was just trying to understand it. Maybe I've been a misunderstanding of mine. Was the reduction in toxicity the primary outcome largely related to the fact that they gave less intense chemotherapy regimens? And if that's the case, I sort of wonder, because that's always something that non-oncologists think about, is how do you target the intensity of chemotherapy most appropriately to a frail older population? Because sort of the way it comes across, I guess, in the abstract, it doesn't really seem to highlight that a really major aspect of the comprehensive assessment is to help in the decision-making about what intensity of chemotherapy you should actually be using.
Yeah, it certainly looks like the patients in the intervention arm did have the reduced dose intensity, more single agent chemotherapy. And I'm not sure that we can conclude with exact certainty, but I think that was the main driver for reducing toxicity. They also did provide patients with more education, handouts, make more referrals to allied health, et cetera, as well, which may have impacted the chemotoxicity. I think what this is so important to note is that the survival at 1 year was the same. So even when we reduce the dose intensity, we're not reducing the survival. So patients can tolerate the reduced dose much better, and they still live just as long, presumably achieving their goals.
What was the study really powered to look at the 1 year mortality? In other words, were the confidence intervals around the 1 year mortality sufficiently narrow that we could exclude a survival difference?
No, it was not. So it just, it suggests that.
Great, thank you. I hate to break up the rich discussion, but for the sake of time and for Dr. Corita Vincent. So thank you very much again, Rachel, for an excellent presentation. You can follow up with Rachel in the chat box or afterwards by email. Our next presentation, Dr. Corita Vincent, PGY4 Geriatric Medicine, to present the ADMET 2 study. Corey, please feel free to unmute and share your slides.
Okay, can see my slides okay? Okay, so I'm going to be presenting the ADMET 2 trial, which looked at the effect of methylphenidate on apathy in patients with Alzheimer's disease. Oops, I have no conflicts of interest to disclose. And then for overview, so we're going to talk about a review of apathy in Alzheimer's disease, including the prevalence, impact, and proposed mechanisms. We'll go through some of the previously examined therapies for apathy in Alzheimer's disease, and then review the ADMET 2 trial and a critical appraisal, and conclude with some bottom line and implications for future research. So apathy in Alzheimer's disease is one of the most commonly reported neuropsychiatric symptoms, and the most common in accordance to one meta-analysis from 2016. The prevalence ranges from anywhere from 19 to 88%, with increasing prevalence with increasing disease severity. So 88% being sort of like more into the advanced stages. And one study found that the 5-year period prevalence of apathy was 70% amongst individuals with Alzheimer's disease. So very highly prevalent in our population of patients with Alzheimer's dementia. And the reason that we care about this is because of the impact that it has on patients and caregivers. So apathy has been associated with increased time for caregivers taking care of their loved ones and increased stress. It's associated with earlier institutionalization, decreased overall quality of life, increased functional impairment, and overall increased mortality as well. So apathy as a syndrome has been associated with all of these things, but it occurs in many disease contexts and is a complicated process. So there's been a number of different neurobiological mechanisms which differ across the different disease causes of apathy. In Alzheimer's disease specifically, the neuroimaging correlates for apathy have been specifically the anterior cingulate gyrus, the ventral striatum, so the anterior cingulate gyrus being the green part here, the prefrontal cortex being the purple, the ventral striatum being the pink, and then the pathways are indicated by the arrows in this image and are really the pathways that are important for our reward system, which seem to be implicated in the cause of apathy in Alzheimer's disease. In terms of the neurotransmitters that are affected, so in Alzheimer's disease, it's felt that there is a decrease in cholinergic activity, which we know, decrease in dopaminergic activity, serotonergic activity, and noradrenergic activity, although noradrenergic activity is less studied. Also in Alzheimer's disease, it's been seen that there can be an increase in GABAergic activity, which also has been associated with an increase. So increased GABA activity has been associated with an increase in apathy, whereas decrease in all of the other neurotransmitters mentioned has been associated with an increase in apathy. So lots of reasons why patients who have Alzheimer's disease could develop apathy. What we also know in terms of the cause of these changes is that apathy is associated also with the degree of tau accumulation, particularly in the anterior cingulate gyrus, and particularly later in the course of dementia, whereas earlier in the course of dementia, it seems to be associated with the overall amyloid burden. But these are all not the most well studied, and so further research is sort of needed to solidify the understanding of the cause of apathy. In terms of the treatments that have been previously studied, so there have been previous research on both non-pharmacological therapies as well as pharmacological therapies. I'm going to focus on the pharmacological therapies for the purpose of this presentation, but just to note that there have been non-pharmacological interventions that have been shown to result in improvement of apathy, and specifically music therapy has the most evidence. But as with all non-pharmacological interventions, sometimes these can be challenging to provide in a clinical context. In terms of the pharmacological interventions, there is a Cochrane review published in 2018, which summarized the different interventions that have been looked at over the years. Notably, only 4 studies were primarily looking at apathy. So the ones at the bottom of this list, modafinil and methylphenidate, were the only trials that looked at apathy specifically as the primary outcome. Others were looking at it as a secondary outcome. With respect to interventions that have previously been examined, so for cholinesterase inhibitors, because of the decreased cholinergic burden and cholinergic activity in Alzheimer's disease and the effect that has on apathy, these were examined. They have probably little to no benefit in terms of clinical improvement of apathy, although some studies have shown that with like higher severity of Alzheimer's disease, there may be more improvement, and there may be a specific effect of some of the newer cholinesterase inhibitors that may be more beneficial for apathy. Interestingly, one study also looked at discontinuation of cholinesterase inhibitors in people who no longer needed them, and they also found little to no effect. People have also looked at antipsychotics, which sort of unsurprisingly, given what we now know about the causes of apathy, with being one of the main drivers being decrease in dopaminergic activity, antipsychotics seem to worsen apathy. But interestingly, discontinuation of antipsychotics in one study also worsened apathy. There's been a number of other therapies that have been investigated, but most of them have shown little to no benefit, and some of them show slight worsening. When we looked specifically at modafinil and methylphenidate, which are similar in their proposed mechanism of action, there's one study only that looked at modafinil, and it showed no statistically significant impact. For the methylphenidate trials, there were 3, all small studies, but in the meta-analysis, they did show an overall improvement in apathy scores. And since the publication of the Cochrane Review, there have been other studies published, but similarly, none of the drug interventions have shown a statistically significant improvement, but there is some evidence for RTMS. So looking more closely at methylphenidate, so these are the forest plots from the meta-analysis from the Cochrane Review. What we saw was that they used 2 different scales across 3 different studies, all with relatively small sample sizes and relatively short follow-up durations. And what the review concluded was that for the apathy evaluation scale, there was a statistically significant improvement in apathy scores, but for the neuropsychiatric inventory scale, there was not. And that scale was only used by 2 studies, one of which was the ADMET one, the Rosenberg et al. 2013. But overall, the quality of evidence, even for the apathy evaluation scale, was considered to be low. They also looked at the overall incidence of adverse events, and they found little to no difference in adverse events between the methylphenidate and placebo groups in these trials, but again, with low quality evidence. So given that methylphenidate is one of the most promising interventions that has been shown in research from a pharmacological perspective, I just wanted to talk briefly about the proposed mechanism. So we know that that methylphenidate has been shown to improve motivation and apathy in non-Alzheimer's. This is one of the reasons that it's been investigated in Alzheimer's disease. We also know that it's thought to work by increasing catecholamine activity in the prefrontal cortex, which then enhances and strengthens those reward mechanisms in the prefrontal cortex. And that's thought to be the main mechanism of action, particularly in ADHD, where it was first analyzed. This image here just demonstrates the difference in rats in terms of the catecholamine activity in the prefrontal cortex before and after administration of methylphenidate. And you can see that there's a significant increase in both norepinephrine and dopamine. But interestingly, bupropion, which is thought to have a similar mechanism of action, it increases both norepinephrine and dopamine as well, has not panned out in terms of the studies that have looked at it in terms of also improving apathy, but they are different drugs, and it may impact the brain in slightly different areas that make it less effective for apathy. There's also only one trial. So that brings me to the current study, which looked at the effect of methylphenidate on apathy in patients with Alzheimer's disease, or the ADMET-2 trial. So they looked at patients with Alzheimer's dementia and clinically significant apathy. It was a multi-center trial with 9 sites in the US and 1 site in Canada. Specifically, it was at Sunnybrook. The intervention was methylphenidate 10 milligrams orally BID as well as a psychosocial intervention that was targeted towards the caregivers. The comparator was placebo, which was also received BID, and they also received the psychosocial intervention. And the outcome was degree of apathy as measured on the neuropsychiatric inventory, as well as clinical global impression of change scale, which we'll talk about it a bit more in detail. So in terms of the inclusion-exclusion criteria, so they included people who had possible or probable Alzheimer's disease, so a clinical diagnosis. There was no requirement for neuroimaging, and they didn't require biomarkers for entry to the trial, but imaging could be used if it was felt to be necessary for diagnosis of Alzheimer's disease. They had to have an MMSE between 10 and 18, and they had to have clinically significant apathy, and there was a specific definition for that based on the neuropsychiatric inventory scale. It had to be deemed that a pharmacological intervention would be appropriate for management of apathy, and that was decided upon by the site clinician. There had to be caregiver availability, which is important and interesting because not all of our patients will necessarily have a caregiver availability. And they had to have English fluency, both the caregiver and the patient, sufficient to participate in the study. So they excluded individuals who had previous major depressive disorder or current, and they used the DSM-5 criteria to report that. They couldn't have current agitation or aggression, delusions or hallucinations. Their Alzheimer's disease medications, antidepressants, and benzodiazepines could be on board, but had to have had no dose changes in the last 30 days. With the exception of trazodone and lorazepam for sleep, and there were very specific dose ranges that were allowed for those. They couldn't have previously been on methylphenidate for apathy and failed, and they couldn't have any medical comorbidities or medication contraindications to use of methylphenidate, so they couldn't be on an antipsychotic or an amphetamine. Interestingly, for the medical comorbidities, they excluded individuals with lack of appetite or unintentional weight loss, although this is not an absolute contraindication to methylphenidate use in other contexts. And they couldn't have had symptoms that were so severe that they required an acute psychiatric admission, and they couldn't have been enrolled in another study that could have impacted the outcome of this one. So this slide has a lot of information, but it goes over a sort of a overview of the study design. So they looked at patients with Alzheimer's disease and clinically significant apathy, and invited them to participate in baseline measures and an inclusion assessment. Patients were then excluded either because they didn't want to come or because they failed the inclusion assessment. After that, they were randomized to either the methylphenidate arm or the placebo arm. For the medication administration, they started out with taking 1 tablet 2 times per day, which would have been a dose of 5 milligrams BID for the methylphenidate group. They took that for 3 days and then received a phone call from the study checking in for side effects and reminding them to increase the dose the next day. And then they increased it to 2 tablets 2 times per day, or a dose of 10 milligrams BID, 20 milligrams in a day total. If any side effects developed during the course of the study, the clinician was allowed to decrease the dose back to the 1 tablet BID or stop if it was indicated. Both the investigators at the site as well as the participants were blinded to the treatment allocation. And both arms received the same psychosocial intervention, which included education materials, counseling, as well as 24-hour crisis availability, which is quite impressive that they were able to offer this, to have an RN or a study person available 24 hours a day to help the caregiver if needed. Interestingly, the psychosocial intervention was not provided if the resident lived in long-term care or if they had a private caregiver who was not a family member. And the total duration of the study was 6 months, at which point the outcome measures were taken and no further medications were dispensed. This is just an overview of when the different measures were taken. This is from the study protocol, which was published as supplemental material for the article. And just to comment that all of the assessments were taken at the beginning of the study, and then some of them were taken at different times throughout, but all of them were retaken at the end. They did include a cognitive battery, which included an MSE as well as the other ones listed on this slide. And then they included a number of safety measures, which we'll talk about in a second. So in terms of the primary outcomes, they used the neuropsychiatric inventory scale, and specifically the apathy subscale that was a part of this. So caregivers were asked to state whether or not apathy was present. And then if it was present, they answered a number of questions about the type, the specific apathy symptoms. Interestingly, the specific apathy symptoms are not included in the overall scoring of the apathy subscale, but what is included in the scoring is the frequency and severity of the symptoms, which are multiplied by each other and give you the final score. They also collected information about caregiver distress related to apathy, and that was included as a secondary outcome. The other primary outcome that they used was the Modified Alzheimer's Disease Cooperative Studies Clinical Global Impression of Change scale, which is a 7-point Likert scale, which was completed by a clinician who was not involved in the study, and based on an interview with both the patient and the caregiver. And they rated them on a scale of 1 to 7, where 1 was marked improvement and 7 was marked worsening with respect to apathy as well as globally. In terms of secondary and balancing measures, they included one other scale for apathy, the DAR scale. They also looked at a scale of activities of daily living and dependence. They included the neuropsychiatric inventory caregiver distress score as a secondary outcome, as well as an estimate of quality of life and an estimate of resource utilization. They also looked at the full neuropsychiatric inventory scale as sort of a balancing measure and to see if there was any increase in other behaviors. And they looked at cognitive testing using the battery that I mentioned earlier. In terms of safety, they monitored for known side effects of methylphenidate, as well as measured some objective measures throughout the study, including vital signs, electrolyte panel, echocardiogram, and weight. A weight loss of more than 7% from baseline was considered to be an adverse event. They also monitored for serious adverse events throughout the study. And there was a safety assessment at the 2-month point. In terms of their analysis, that they did a power calculation based on the ADMET trial, the first one. And based on this, they estimated that they would need 200 participants for a 90% power to detect a difference of 1.8 on the neuropsychiatric index, or inventory rather, that was what had been seen in the first trial. From this, they estimated that they would have 85% power to detect an odds ratio of 2.75 on the Clinical Global Impression of Change scale. And both of these estimates were based on an assumption of 15% loss of patients. They did use intention to treat analysis. For the neuropsychiatric index, they looked at the difference in mean change from baseline to 6 months and evaluated longitudinally using a linear mixed effects model with random intercept for each participant. They adjusted for clinic, age, sex, and diabetes status. And diabetes status was adjusted for because there actually was a difference between the two groups at baseline. They also looked at Kaplan-Meier estimates to determine the timeline of incidence of absence of apathy symptoms. So if they scored 0 on the neuropsychiatric inventory, that was considered to be an endpoint on the Kaplan-Meier estimate. For the Clinical Global Impression of Change, they looked at proportional odds logistical regression, and they did not report the method of analysis for the secondary measures. So this is the table 1, which has a lot of information. The population actually is very similar to the one that Rachel described in her study. So mostly men, average age of 75, predominantly white, and of a higher education status, and mostly married. One major difference between the two groups was diabetes status, with 10% of individuals in the methylphenidate group having diabetes, but 20% in the placebo group. In terms of the results, so at 6 months, they measured the change from baseline on the neuropsychiatric inventory, and the mean difference between the two groups was 1.25, with a range from negative 2.03 to negative 0.47. The p-value was statistically significant, and the Cohen-D estimates a mild to moderate effect size. So this means that in the methylphenidate group, on average, they had a reduction of their apathy score of 1.25 more than the placebo group. With respect to the Clinical Global Impression of Change score, the odds ratio between the two groups was 1.9, but it was not statistically significant. When they looked at the mean change in the clinical global impression of scale from 0 to 6 months, they actually did see a clinically statistical difference, although the odds ratio was 1.43. Although the clinical global impression of change scale itself, as originally planned to be tested, was not statistically significant, there was a high degree of correlation between the neuropsychiatric inventory and the global impression of change score. Looking at figure 2, you can see that on the neuropsychiatric inventory, there was a difference at 2 months between the placebo and methylphenidate group, which persisted throughout the remainder of the trial. And similarly, on the Kaplan-Meier estimates, you see that at 2 months, about 100 days, is where the distance between the placebo group and methylphenidate group is the largest, and then it persists sort of throughout the rest of the study. For the whole study period, the hazard ratio was 1.57, which was not statistically significant, but when they looked at specifically the first 2 months, it was statistically significant with a hazard ratio of 2.1. And the reason that it may have not remained significant throughout potentially could have been the sample size. So with respect to adverse events, they reported 17 serious adverse events in the methylphenidate group and 10 in the placebo group. However, all were deemed to be unrelated to the study. For participants in the methylphenidate group, they were noted to lose more weight than those in the placebo group, which was the only significant adverse event that was noted. In terms of the other measures, so on all of the other scales, the only thing that came up as being clinically significant or statistically significant was a change in the neuropsychiatric index aberrant behaviors. So there was an increase in aberrant motor behaviors in the methylphenidate group in comparison to the placebo group. There was no change in any of the other neuropsychiatric symptoms, and there was no change on any of the other scales included in the study as secondary outcome measures, and no difference in the cognitive measures. So in terms of limitations, just before we go into the critical appraisal, the patient population is a limitation in the sense that it was a convenient sample. It was predominantly white, they were higher SES, and all had an engaged caregiver, which is not always the case in a common geriatric practice. The diagnosis of Alzheimer's disease was clinical, which may have resulted in people being included in the study who did not truly have Alzheimer's disease. However, arguably, this includes improves the external validity because most of the time we are doing clinical diagnosis for Alzheimer's disease patients, and no information was collected about patients who failed the screen or declined enrollment. The treatment duration was limited to 6 months, so we don't really know what happens to these patients with longer duration of therapy. And there was no measure of overall impact on the caregiver or the patient. So there was no global measure of caregiver burden, although they did look at caregiver distress related to apathy, which was not significant, and no measure of overall caregiver or patient satisfaction. So with respect to the validity of the results, so there was randomization, it was computer generated and in a permuted block design stratified by center. The groups were mostly similar at baseline, with the caveat being that there was more diabetes in the placebo group than the methylphenidate group. Aside from treatment allocation, were the groups treated equally? Yes, so it was double blinded and patients had the same protocol regardless of their treatment allocation. The medications were identical in the appearance of the tablets and packaging, and it was a computer that told the sites which medication box to dispense to each individual. And in terms of the analysis, so there was a dropout rate of 8.5%, which is less than 15%, which was accounted for when they did the power calculation. And it was 6.9% for the placebo group and 10% for the methylphenidate group, so a bit higher for the methylphenidate group. They did use intention to treat analysis. And as mentioned, both the participants and the clinical center personnel were masked to the treatment allocation. There was a specific set of personnel at the coordinating center who were unmasked, who performed the 2-month safety assessment and were able to unmask in the event of a medical emergency. So we talked about the results already, but in terms of how large the treatment effect was, so the confidence interval does not cross 1 for the neuropsychiatric index. and it is statistically significant with a p-value of 0.002. The Cohen-D indicates a mild to moderate effect. But it would be important to know whether we're hitting more of a 0.5 point difference or a 2 point difference on the neuropsychiatric index, because from a clinical perspective, it may be hard to say that a 0.5 difference on a scale is something that could be clinically significant. There may have been not enough power to detect a clinical significance on the clinical global impression of change score, based on the idea that there was significant correlation between the two measures. And this was not the power calculation was originally based off of the neuropsychiatric index, not the global impression of change score. For the secondary outcomes, they again didn't report how they measured them. No p-values were given, but they reported that there was no statistical significant difference. We talked about how precise the measures are. And then in terms of adverse events, so really the only one that was noted was this weight loss amongst the methylphenidate group compared to placebo. And then this increase in aberrant behaviors, which was more of a balancing measure, but it would be important to know whether that ends up being something that increases caregiver burden in the long term. So will these results help me caring for my patient? I think this is difficult to answer, but in some cases, I think the answer could be yes. But as mentioned in the limitations, this is not our average patient population, so it wouldn't be generalizable to every patient with Alzheimer's disease and apathy that we're seeing in our clinics. But amongst that subset who would have qualified for this study, there may be some benefit for methylphenidate. Is the treatment feasible? I think yes, it doesn't require any more monitoring than some SSRIs when initially started. And would the potential benefits outweigh the potential harms of the treatment? So the potential harms were low, specifically weight loss, which can be monitored and the treatment can be stopped if weight loss is occurred. But also the potential benefits, I think at this point, we're looking at a scale, which may end up being clinically significant, but the absence of the quality of life or ADL improvement, as well as an absence of measures of caregiver burden or patient satisfaction, leave us wondering how clinically significant this would be for our patients. So the bottom line is that methylphenidate resulted in improvement of apathy in this study in comparison to placebo. There's limited generalizability based on the patient population, and further research would be needed to clarify if we can extend this more broadly. Thank you. Are there any questions?
Thank you, Corey. That was tremendous. So well presented, and such a great nuance of understanding with your concluding remarks. I will open it up to the audience for questions. Gary has his hand up. Go ahead.
Very nice job, Corey, presenting. Thank you. Just a couple quick questions. You presented the Cohen-D, so suggesting that it was what I'd call modest benefit. Is this consistent with the literature that looks at minimally clinically important differences in items on the NPI? And maybe it sort of relates to my second question. I mean, I've sort of always looked at the NPI sort of like an MMSE. It's more of a global measure across multiple, I think it's 13 different behaviors. And in other type of behaviors like agitation, often when they have pharmacologic trials, they do not use something like the NPI, but they use a specific measure that is a more detailed measure of that type of behavior, like the Cohen-Mansfield agitation scale when they're looking at agitation. So it just seems maybe a bit unusual to me that they've used what I would consider a fairly blunt instrument or measure of apathy. And I guess I'm curious, like when you looked at the meta-analysis or the literature you've reviewed, are there other measures of apathy that perhaps are more specific to that one behavior that in the future may be at least advisable to consider rather than just an NPI apathy item? Thank you.
Yeah, it's a very good question. So actually in some studies, a score difference of about 4 points on the neuropsychiatric inventory. So that's more looking at change from baseline, which they did have a change from baseline that was more than 4 points. But there was not a 4-point difference between the placebo group and the methylphenidate group, would be sort of considered clinically significant. The other problem with the neuropsychiatric inventory is they do collect that information about the type of apathy and the type of apathy behaviors, but they didn't include that it's not included in the score and therefore wasn't included in in this analysis. There is actually a lot of ongoing research into scales and scoring of apathy, which there is ongoing, and there's not really a good measure. Like the ones that were included in the meta-analysis originally was an apathy evaluation scale, which seemed to be more robustly associated with improvement with methylphenidate. But when it came to this trial and the planning of it, it's a very difficult scale to administer, and it requires a lot of training of the investigators. And so it was felt to not be feasible for this larger scale study to use this apathy evaluation scale. So I think what they probably were hoping was that the clinical global impression of change would have been positive. And there is some evidence that it was correlated, but may have not had the power to detect a difference because they didn't achieve the odds ratio that they were expecting with that. So I think, like I mentioned before, like those clinical and sort of more patient-centered outcomes will be really important in the future.
Thank you, Corey. Some comments in the chat box as well. Shabir notes, are local geriatric psychiatrists prescribing methylphenidate based on this trial? Give that a moment if anyone wants to reply. Shabir, I do not know. I have not seen it in the patients that intersect with geriatric psychiatry in my practice. Christina Repis notes, excellent presentation. I find it interesting that so many, 40%, were on memantine. Does this mean most had moderate to severe AD, or a function of maybe a motivated patient population more likely to be included in trials?
Yeah, I suspect the latter, like highly motivated individuals. Also such engaged caregivers, like they had to have an engaged caregiver, which is so different than many of the patients that we see in our practice as well. I would comment also on the Geri psychiatry. So I don't think that that it's being regularly used for apathy, specifically in Alzheimer's disease, but I have seen it used for apathy sort of maybe in even with Alzheimer's disease, if you would say. So not because they have Alzheimer's disease, they get methylphenidate, but they have such severe apathy, nothing else seems to be working. They maybe also have Alzheimer's disease, but maybe we could try methylphenidate because we're really out of other options, and maybe it'll have a clinically significant improvement for this patient, is sort of what I've seen with a couple of patients, only a few.
Thank you. And Carol also notes in the chat box, yes, perhaps some colleagues at Sunnybrook are using it. I wonder, Corey, there's sometimes concern about cardiovascular adverse effects. And so you mentioned weight loss, and overall, generally, although amazing study with 200 or so patients, you know, could any comment be made on that adverse effect? Obviously not. And I wonder if there's any concern about that.
I think the way they tried to get around it was to look at the things that are thought to drive the cardiovascular outcomes, which were like our tachycardia and hypertension. But yeah, I think it would need a bigger trial for a longer duration to know for sure if there's long-term effects.
And Shabir's final comment in the chat box to Shabir, certainly there is a little enthusiasm for using it in cancer-related fatigue in Geri and particularly non-Geri populations. So extends on what Corey may have said. So with that, we have 1 minute to the end of the hour. Thank you very much to both Dr. Rachel Johnston and Dr. Corita Vincent for